General anesthesia is a medical profession that very few of us have interacted with, but it is such an important profession in our world because they are the people who help to put us to sleep so that we can have our surgeries. So we'll be demystifying this for you today. So this is the Dr. Tebz show where we're putting your health back into your hands. My guest today is Dr. Ettienne Coetzee. He's a qualified anesthesiologist who works at the Anesthesia and perioperative units at Groote Hospital and Red Cross Children's War Memorial Hospital. He has got vast experience in this he's doing this on a daily basis. So I'm so privileged to have him here with me today. So thank you so much, Ettienne, for being with me here.
Thank you so much for this opportunity, Tebz.
So, Dr. Coetzee, many people don't know about anesthesia. You know, they only meet you when they come for their surgeries. So you're going to help shed light on this, right?
Yeah, no, I think you're absolutely right. We often have a very limited interaction with our patients. And I think this is a great opportunity for us to demystify some of the nuances and details about general anesthesia.
So what is an anesthesiologist? Let's start there.
So an anesthesiologist could be a general practitioner with special interest in anesthesia, or it could be a specialist anaesthetist that's spent extra time after his medical studies to further his or her skill in general anesthesia or regional anesthesia, depending on the type of case that you are doing. We typically employ, in government practice, some medical doctors that are either diplomat anesthetists, so they've completed a diploma in anesthesia, or specialist anesthetists, so that they've gone through additional training to become a specialist anesthetist.
Okay, so then what is general anesthesia then?
So that's a very good question, and not a lot of people are aware of what happened to you, or what's going to happen to you when you go under an anesthetic or an operation. So as an anesthetist, he or she will be in charge of changing your consciousness into a state where you are unresponsive, you can't feel pain, you aren't aware of your surroundings, and you are lying completely still so that you can safely undergo a surgical or diagnostic or some operation. And that's where we come in. We actually will provide you with medication that will temporarily render you unconscious and unaware, and at the end of the procedure we stop the administration of those medications and then render you back into a conscious state.
So I've had a lot of gogos tell me when I tell them that they're going to go for surgery, they're like, oh, you're going to kill me, then resurrect me. So basically that's not what you're doing.
No, what we do is if you are providing anesthesia, the medications that we use will hinder your body's normal function.
Yes.
And for us to do a safe anesthetic, we will connect you to a lot of monitoring devices that we can safely provide you with this while monitoring your heart and your lungs and your temperature. Those are all processes that we will hinder with our medications. So we have to support those. We can either breathe or assist you with breathing. We can assist you by maintaining your body temperature, and we can assist your heart and your cardiovascular system during this time.
Okay, so before I ask you how you administer general anesthesia, I think it's important to revise a bit of the anatomy. Okay.
Sure.
So can you give a nice overview or outline of what are for example, the trachea, the larynx, all of that patients the viewers at home can understand that when you're putting them to sleep, these are the structures in which you're interacting with, basically.
Yes. I think as an anesthetist, we are intricately involved with maintaining your breathing and protecting your lungs and your airway. So to have some form of understanding of what we deal with will be very useful. Typically, we will put up an intravenous cannula, which you call a drip, and we will administer what we call the start of anesthetic, the induction of anesthesia via this drip.
Okay.
We will then typically have to support your breathing during this time, and you might notice your anesthetist telling you, we're going to give you some fresh air or some oxygen during this time. At that point in time, we typically render you unconscious.
Okay.
And we will now have to support your breathing. During this time, we will have to either insert a tube or an airway device to protect your airway. So thinking of the anatomy that we are looking at, from the mouth, the teeth, the tongue, if we go deeper, you will find your soft and hard palate. But we actually have to deal with even anatomy that's deeper than that.
Okay.
Up to the trachea. So we first have to go through the vocal cords, which we call the larynx. Those are all structures that are intricately involved. On top of the vocal cords, you have your epiglottis.
Yes.
And this acts as a little valve to close off your trachea, which is connected to your lungs, during a swallowing process, so that you don't accidentally spill into your trachea when you eat or swallow or drink stuff. So those are all structures that we have to look out for and manipulate during the procedure of establishing your normal breathing pattern during the anesthetic.
Okay, so now you've explained that, okay, you've done the drip, you've put up the tube, and then you've said that then you monitor the patient. So basically this is the whole thing about general anesthesia. But then other than just supporting and monitoring, you know, what other small little things, like for example, pain management, or like just go into a little bit of that.
So dealing with the anesthetic requires typically 3 pillars. We always call it like the tripod chair.
Okay.
It's the hypnosis. And that type of medication will render you unconscious, but also prevent you from remembering any experiences, and also render you completely unaware of your surroundings. The next medication or focus of what we would do is to obliterate any noxious stimuli or pain. Now, when you're unconscious, you cannot consciously perceive the pain, but your body can still react and put you into a fight or flight mode. And that's something we want to avoid by giving you pain medication to treat that pain. And the last pillar would be to keep you completely immobile. Now, especially in your field where your surgeries are very delicate and you're working through a microscope, even minute movements can cause a significant problem for your surgery. So we have to keep patients completely still. And typically the easiest way that we can do this is to give them a muscle relaxant medication. And I don't want to call it a paralytic drug, but that's basically what it is. It renders your muscles completely immobile. Now, at the end of the procedure, we will give you a medication that reverses this and give you your full muscle strength back. But that will only be done once the procedure is done, but before we wake you up.
Okay. That's good. All right. So having said that, what is the difference between general anesthesia and conscious sedation? Because a lot of people sort of have heard this word and they say they prefer conscious sedation over general anesthesia. Can you explain why you'd pick, number one, what is it? Number 2, like why would you prefer conscious sedation over general anesthesia in some cases?
So the role of conscious sedation is to try and alleviate some of a patient's fears or anxiety when they come for a procedure or a diagnostic intervention. So it's typically done if the procedure that you're coming for is not painful. Or, for example, you've numbed the patient's eye, so you now can do the procedure without any pain, but lying underneath all those curtains and stuff can make you very anxious. So then we provide you with a low dose and a small amount of anesthetic drug just to render you a little bit euphoric and to administer something that will take the edge off and just or decrease your anxiety to a certain degree. That being said, because we can give you less of the drug, it's typically less impactful on your normal body function. So in someone that's very sick with poor heart and lung function, we might say it might be safer for you to get complete numbness of your eye or whatever body part we want to work on, and then just provide you with a light sedation to just alleviate your anxiety for being in theatre. Why
is it then that a patient must not eat before going for general anesthesia?
A very good question, and it's something we often struggle with, especially in our children and pediatric patients. Now, if you eat or drink any foodstuffs, your stomach fills up and keeps that as a reservoir as you start to digest the food. Now, in normal eating, that takes a few hours for your stomach to completely empty.
Yep.
While you are awake and aware, you can protect your lungs from the accidental spillover. You can imagine when you are accidentally swallowing some water or something and it goes into your trachea, the instant cough reflex that you have to protect yourself against this, what we call aspiration.
Yes.
So that protective reflex is lost when you go under anesthesia. And for that reason, we keep patients, we omit giving them any food or drink for a certain amount of time. Now, the specific type of food and type of drink that you will have will determine the duration that you will need to omit any eating or drinking. For example, if you're having any solid foods like fruit or vegetables or meat or fish, those will stay in your stomach for quite a long time.
Yes.
So our guidelines recommend that you stay free of those for at least 6 hours before an operation. Stuff like clear fluid, like water or clear apple juice without any particulates in it. We typically tell patients if you can see through it, it's clear.
Okay.
So those type of liquids you can take up to an hour before. So we try to promote, especially in children, having some of those clear fluids so that they don't become hungry or too thirsty beforehand.
True.
We also make an exception for breast milk. Because it's a natural protective product, we will allow 4 hours.
Okay.
And typically after 4 hours, it's safe to proceed with operations. So there are some international guidelines that are more strict with a specific type of food. But for us, we try to reduce confusion and say, listen, anything that's not clear fluid or breast milk, we will say rather stick to a safe margin of 6 hours. For breast milk, it's 4, and for clear fluids, we say 1 hour.
Okay. Yeah. So, are there any medical conditions that put a patient more at risk of the complications from anesthesia?
Absolutely. There are some medical conditions that are specifically anesthetic risks, but they are quite few and far between. There's 2 specific conditions that are associated with the anesthetic medications that we give. The one is called malignant hypothermia, but that's a genetic inherited condition with some of the conditions that can spontaneously occur, which is extremely rare. That is the condition where you exhibit an acute response to the drugs that we give you, and it can be life-threatening. But you will typically have family history of this.
Yes.
And it's a very small proportion of patients that suffer from this, extremely small.
Okay.
It typically happens 1 out of every 25,000 anesthetics in the world. So it's a very, very scarce condition. The other one is called anesthetic-induced rhabdomyolysis. And this is a condition that's got a similar presentation of hypermetabolic rate and muscle disease and muscle weakness.
Yeah.
Which is associated with muscle dystrophies.
Okay.
So again, you will typically have family history and you will know about this. And it would be very important to notify your anaesthetist about this condition. But in general, we in the adult population, we have to deal with their medical conditions like high blood pressure, their sugar diabetes, and some of them with lung conditions like asthma, or chronic obstructive pulmonary disease.
Yes.
Those conditions can put you at an increased risk. But for those patients that, during our pre-anesthetic interview, we will elicit those, we will either do a special procedure or we will upscale their monitoring, or we will ensure that when the operation is completed, we deliver them into a high care, intensive care unit afterwards. So it is important to notify your anaesthetist about any chronic illnesses that you have or other history, especially if you've had an operation before. You can tell your anaesthetist about bad experiences or drug reactions that you had, to make your anesthetic safer.
True. And then in children, because the reason why I'm asking these questions is because patients don't tell us that this is the problem, that they have this. And if all of a sudden you find yourself, even for myself as a doctor, they don't tell me. They tell you when you get stated, but I don't know. So now for the parents, you know, I want to ask this question. In children, what are the important medical conditions that they should say, this is what my child has, because that puts them at risk of complications from anesthesia?
Yes, so I think in the pediatric population or in children, we often deal with complications of the lungs, especially during the winter months. Your child might have some cold or flu. It's a very common occurrence, and these conditions can increase the possibility of a respiratory complication or a lung complication. Typically something like they develop severe constriction of their lungs, so they might have some breathing difficulties in the induction or shortly after the procedure. So what we tend to do is, if we pick up that there's an acute infection, we tend to delay their surgery with a week or two, typically 2 weeks, so that they go through the worst of their lung infection or chest infection and recover somewhat. If we are in the recovery phase, the chances of a complication occurring is a lot less.
Okay.
Some of the other difficulties that we run into are that if we're dealing with children with some neurological disorder. This can be something ranging from cerebral palsy to someone with autism. These children can, you know, they can present us with some challenges during the induction period. They are not necessarily going to cooperate or follow commands like, you know, in the norm. So we have some strategies to get to a appropriate interaction with a child, and we try to cooperate with the family, the friends, and the child, and get them familiar with their environment, and to make it as easy and as delightful and as pain-free as possible during that time. So that's where parents become a vital armamentarium during this process, if we've got good communication with the child and the parent.
Many patients are very nervous about going under general anesthesia because they're afraid of dying. Okay, other than dying being a complication. And you mentioned, you know, this malignant hypothermia and all of that. But what are some of the other complications, other than aspiration, you said, and so forth? Is there anything else?
So one of the most common complications that we run into in the post-operative time is patients either suffering from pain or from nausea and vomiting. So I think it is very important that the anaesthetist establishes some good communication with the patient, so that the patient feels free to tell the anaesthetist about these problems. And we can't really ensure that you will wake up completely lucid and without any pain. And I think it's important for the anaesthetist to be honest and say, there might be some pain, there might be some nausea, but we have medications to treat these things. During the anesthetic and during the procedure, we will already start to administer some of those analgesic agents and pain medications, as well as medications for nausea and vomiting. But it might be insufficient, and it might not completely render you pain-free or without nausea. And then it's important to notify us and to have a good patient-doctor communication to say, listen, I still have some pain, or I still feel nauseous. We have other strategies that we can employ. And we will ask you beforehand. We have some risk factors or some questions about your nausea and vomiting. And if you fulfill some criteria, we might already prophylactically give you medication.
Okay.
Other complications that can arise that are much rarer would be damaging to your dentition or a nick on the lip. But those are very rare, and I think it is something that as an anaesthetist we really try to avoid because it has significant implications.
Yes, very true. I wanted a patient who the anaesthetist, he didn't tell her that the tooth was an artificial, what's it called, an artificial, it was implanted in the And it got knocked. And we had to do an x-ray, and there it was sitting in his tummy. He was not happy. Sure. Yeah, so it does happen.
Yeah, fortunately, it's very rare.
Yes.
But it is a complication I think your anaesthetist should make you aware of.
And you should tell your anaesthetist.
And you should tell
that
definitely.
Your teeth are not your teeth.
Absolutely.
Very true.
You should also try and remove any, I mean, if you're coming for an eye operation, you will obviously remove your contact lenses and so forth.
Yes.
But it's also something you should probably remove before you're coming for any other operation.
That's a good advice. So, second last question. Can a person choose their anaesthetist?
So, in the government sector, it is a little bit more difficult to do that. If you look at how we roster our anesthetic service, we typically try and roster specific people for specific lists, or we try and have everybody, participating in the roster as a whole. So it is a bit more difficult to request a specific anaesthetist, but I can certainly see that it might be worthwhile to attempt if you really feel strongly about that. I think in the private sector, the surgeon has a large say about which anaesthetist he or she prefers to work with.
True.
So it might be quite difficult to request a specific anaesthetist in that field.
Yes.
But we are a nice bunch of people, so we will always treat you really nicely.
True. All right, so what are your closing thoughts on this topic of general anesthesia?
I think it's often something that people know very little about, and it's something that they can be scared of, but it is worthwhile to know that we have a good training society in South Africa to make sure that your anesthesia is as safe as possible.
Okay. No, thank you very much, Dr. Coetzee. This is a very insightful discussion, very comprehensive. So thank you very much for being with me today.
Thank you for this opportunity, and it's lovely to work with you.
Thank you. And to you viewers, thank you so much for watching this episode about general anesthesia. I hope that you've learned a lot today, and yeah, you have a bit more insight into what is general anesthesia. But if you have any comments or questions, please leave them down in the comments box below, and we'll get back to them. So remember to like, share, subscribe, and push that notification button so you know when we post our next episode. So until next time, please do take care of yourselves, take care of each other, and remember, your health is in your hands. God bless.